So the agenda for today, we've got two fantastic presenters. We have Associate Professor Melissa Nott, who will present, and then we will have a Q&A session that will be for about half an hour. And that will be followed by Gerard Mansour, who's the Commissioner for Senior Victorians and Ambassador for Elder Abuse Prevention. And he will also present and have a Q&A session for about 30 minutes as well. So Melissa, we will start with you if that's okay. And Melissa is an occupational therapist with a passion for working with older people and people with long-term neurological conditions. Melissa previously chaired the Ageing Well Research Group at Charles Sturt University, and she's now the Principal Research Fellow at Charles Sturt University's Department of Rural Health. Melissa's research focuses on supporting OTs and multidisciplinary teams to translate evidence into clinical practice to achieve person-centred, meaningful outcomes for clients, families, and communities. So Melissa, I will hand over to you.
At all. Okay, so I would really like to also begin by acknowledging the traditional custodians of the land on which I'm zooming in from today, the Wiradjuri people, and acknowledge my gratitude that we share this land, my sorrow for some of the costs of that sharing, and my hope and belief that we can move to a place of equity, justice, and partnership together. As you all will know very, very clearly from your work, people living in rural and regional communities within Australia experience some really unique challenges, and that's not just to do with geographical isolation, but increasingly also to do with social isolation, particularly as younger people are moving away from rural areas to seek employment in more urban areas, resulting in a large proportion of older people living in rural Australia. And we know that the health and well-being of older people is further compromised by things like service availability, access to healthcare, poor access to transport services, and those progressive losses of social networks. And in the area that I live, Albury-Wodonga, sorry, I'll try to keep ignoring the little beep beeps. The local population here is just over 50,000, so about 51,000, and we have a 24% of that population is aged over 60. And that is significantly higher than in other areas of Australia where the general population over 60 is only around 15%, or sorry, over 65 is 15%. So we are significantly higher in this area that I live in terms of our proportion of older people. And so back in 2017, a colleague from Albury-Wodonga Health, so an OT and a physio who I'd been doing some work with on a stroke self-management program, started to talk with me about the needs for some services for older people living in our community that focused on healthy ageing rather than on management of specific medical conditions. And at that point in time, through the local health services, basically every program available required you to be sick already to be able to get into those programs. So to enter a falls program, you needed to have had a fall. To enter into a memory group, you needed to be diagnosed with mild cognitive impairment. So there was this real barrier to accessing services, a real reactive approach to providing programs after people had been diagnosed with the medical condition, but no real early intervention model for supporting older people living in the community to prevent them from getting unwell. So with this in mind, we started a broader community engagement program to try and identify what older people in our community would like in terms of a healthy ageing program and what they felt was needed. And so based on the feedback from our stakeholders and from our community members, we identified some core elements of an Ageing Well program that we could pilot through Charles Sturt University. And on the screen here are some of those key elements. So the main things that came out of our consultation process was that a program needed to be multidisciplinary and multidimensional, and in particular focusing on aspects of physical health, primarily mobility, cognitive health, and maximising maximising independence. There was a very clear desire for people to be lifelong learners, and our community members really clearly said they wanted to keep learning how to be safe, healthy and well so that they could stay living at home. It was very clear that everyone wanted socialisation, so having a social component and some fun was a really key aspect. The program needed to be physically accessible to the community, to be delivered at low or no cost. And our stakeholders had clearly identified the need for participation to not require any type of age-related disorder or any kind of medical condition. So it was interesting to note that even though this occurred back in 2017 when we did this consultation, the core elements that we built into our program have been resonated through the recommendations of the Royal Commission that clearly have said that our approaches need to assist older people to live active, self-determined and meaningful lives. They have the right to continue to enjoy social participation. Older people should be supported to exercise choice and be able to take risks, and that programs should emphasise restoration and rehabilitation with the aim of supporting physical and cognitive capabilities. And so while these recommendations weren't there, clearly our core elements were on track with what was to come. So we looked at these core elements and tried to figure out where shall we run this program. And in the end, we decided to run at least the initial pilot of the program through our university's Community Engagement and Wellness Centre, which is based on our university campus in one of the suburbs of Albury at Faguna. And it already provides a lot of, it provides clinics for community members to attend, which integrate student learning as part of those clinical placements. And so we also wanted to adopt and support students to learn about healthy ageing and working with older people as part of our Ageing Well program. So it did run through our, we call the Community Engagement and Wellness Centre, CUE for short. And we really wanted to design something that was a bit different to what had been offered before, or to what was already being offered within our local area, that was really meaningful, that met the community's needs and sort of wasn't just another healthy ageing program. So we looked at the evidence, and by far and away the strongest evidence in terms of multi-dimensional or multidisciplinary programs for older people focus around what's referred to as dual tasking programs. And these are essentially activity-based programs that integrate both physical and cognitive components to them. And they're done in all sorts of different ways, but essentially the evidence from these programs suggests benefits for memory and executive functioning, improved attention and improved functional mobility. So we designed the activities that formed our program based around the evidence on dual tasking. I have a background in acquired neurological conditions, so I have a real interest in adult learning and different learning approaches. And so we wanted to integrate in our program a strategy training approach rather than repetitive practice, task-specific training type approaches. So we integrated cognitive strategies as part of our program. And we're also very aware that many programs that are centre-based, the skills that are learnt in the centre don't often translate well to the home setting. And so we really included in our program a very intentional bridging process between what was being learnt within the centre and then what clients were following through with at home. And that was through supporting both participants and our students to learn how to do that. We put out a general call for interest within our local community through traditional media, so radio, television, print newspapers, social media, and you can see on the slide there what our screening criteria were. We wanted to run a pilot with about 12 people to begin with, and we had 70 people contact us in the first couple of days. So we certainly felt like we had identified a need for people. So we have run the program several times since that first round, but the screening criteria have remained the same as what's on the screen. So during the screening process, we used the Canadian Occupational Performance Measure to ask participants about what was most important to them. And our program was then built around that. So the three main areas that our program was built around were mobility, so indoor and outdoor mobility, things like improving balance, enhanced confidence, reducing pain, reducing fatigue. Cognitive skills, so improving memory and confidence, being less distracted, better attention, particularly at multitasking. And then a focus on activities around and within the home. So gardening was a really key area for a lot of people, and other domestic activities. We then paired up each participant with another participant based on their goals and their abilities, and we matched them to a student. And then these three people worked together in a triad for the 10 weeks of the program. So we aimed to meet a lot of the socialisation components at the start and the end of the program each week, where we worked together as a large group with some of the educational components. But then when we actually went down to working on the dual tasking activities, everyone worked in their small triads. And some of the feedback that we'd received from community members about working in a group setting was that they often, some language and hearing difficulties made it hard when working in larger groups. And so that was alleviated when we were in the smaller triads. It was easier to pay attention and follow the instructions of the student. It also meant that people didn't feel like they had to keep up with everyone within the group. They were working just within their smaller teams. So a lot of the concerns that had been raised about group programs were alleviated by this model of being able to work as a larger group and then in the small triad supported by our students. So each week when participants arrived, we spent, as a large group, spent about 10 minutes talking through what the cognitive strategies were that we would be focusing on that day. And a lot of them centred around fairly simple sort of global cognitive strategies such as stop, think and do, before then engaging in the dual tasks. And so then after the large session, the participants would go off with their student, and we used the Community Engagement Centre plus also the university campus and the local area around Thaguna for some of the more community-based activities that we did. So they would engage in 2 different dual tasks and they would vary each week. And then at the end of that, we would come back and do a debriefing, identify things that were fun, things that worked really well, things that didn't work well that week, and start to do some planning for the following week. I've touched on the types of activities that we included in the program, and the point to really, I guess, make here is that we really wanted the activities to be challenging. And one of the things that participants said they clearly didn't want was a prescribed set of exercises to do every week, as they found that fairly boring and not very challenging. So every task had built into it 4 levels of motor challenge and cognitive challenge. And so we would work with the students to progressively move people through these different levels of challenge. So for example, we could change the motor challenge of a task by changing physical posture. So from doing a task in a seated position to a standing position or to a more dynamic position. We could change the requirements for balance or strength, the surface that people were perhaps walking on, or the gradient or the slope. And we could change the cognitive challenge. So by increasing demands, for example, on memory skills, visuospatial skills, planning or problem solving. So it might be, for example, at the beginning of an activity, the participants might read through a short piece of information out of the newspaper and need to remember that and tell it to their partner as they were walking over to the shops. And then to increase the level of challenge, the other partner would need to remember something and say it back to them, and then they would have to pass that on to the student when they got back to the centre. So increasing the requirements for both motor and cognitive abilities every week. And so part of our debriefing with students each week was really planning how can we grade up the motor and cognitive challenge for each participant. And within those triads and the partners, they didn't have to always go up at the same time. We were quite flexible in how we were able to individualise that. So our real aim was for the activities to be both challenging and fun. We also wanted to collect some information along the way in terms of gaining some research evidence around the effectiveness of this type of program. So we did collect standardised pre and post measures, which included, as I said before, the Canadian Occupational Performance Measure, a quality of life questionnaire, the MMSE, a patient-reported evaluation of cognitive state, timed up and go, and the 6-minute walk test. We've since added to this some more qualitative aspects where we've interviewed participants and their family members following participation in the program. And we now do a 12-month follow-up as well with all group participants. So our original pilot, I just wanted to share some of our initial findings with you. So we had an initial pilot group of 11 and we compared them to a control group who were waiting to receive the next version of the program. They were in their mid-70s, mainly female, about 50-50 split in terms of living at home, either alone or with someone. About a third of the group had had a fall in the previous 12 months. So a fairly standard community cohort. We evaluated program feasibility and we had close to full attendance each week of the program, and where non-attendance occurred, it was due to illness or difficulties with transport, and we had no adverse events that occurred during the program, which is interesting given that we were certainly challenging these people quite significantly from a mobility perspective. So as an example, you could see here this lady, she's standing on a balance beam, needing to maintain balance whilst doing a dynamic activity of catching the ball, and she was also reciting one of her favourite poems at the same time. So a really high cognitive motor load, and we had very high, some activities had higher levels of risk, and we discussed that with participants beforehand. They were being closely supervised, but we didn't have any adverse events during the running of the program. So in terms of some initial outcomes, with the COPM, which was our primary outcome measure, our participants rated their performance as increasing from around 50% to 75% over the 10 weeks of the program on their performance measures, and from 50% to 70% on their satisfaction with how they were performing daily living activities. And these changes are highly significant from a research and statistics point of view. For those who are nerdy numbers people like me, you'll love this slide and everyone else will cringe and hate it. The things that I really want to draw your attention to, our intervention group, in terms of the everyday cognitive skills. So this is reporting how many times their cognition is impacted on a day-to-day basis. So a reduction is what we're looking for here. So there's quite a significant reduction in how many times a day they feel that their cognition is impacting on them. And that change was significantly reduced over the 10 weeks of the program, as was the distance that people were able to walk with the 6-metre walk test. And so these are really positive, encouraging results over quite a short-term program. The lovely thing that we can now report is that these gains have been maintained in our 12-month follow-up. So I guess some brief take-home messages in terms of this type of program. There is an increasingly strong body of evidence that supports dual tasking interventions for older people. Ours was certainly one of the first to look at doing so in a rural community. The protocol that we used was safe, feasible and effective, and the measures that we included were sensitive to change. But the real take-home message is that the co-design of this with local participants and stakeholders was critical to ensuring that the program purpose was clear and relevant to our local community. We're in the process of applying for some funding to be able to keep our program going, because as we know, nearly all community-based programs suffer from issues with sustainability. So that's where we're at right now, trying to receive some search for some external funding. And our partnership with Albury-Wodonga Health is ongoing, and two of our, it says on the slide here new graduates, but they probably are not new anymore. It's a couple of years since they've graduated. So a couple of our OT graduates who were students who were involved with the Ageing Well program have now rolled with it at Albury-Wodonga Health, and have slightly repackaged it to it's now being called Hello 65, Healthy, Energetic and Loving Life over 65. And they're implementing a very similar set of outcome measures and activities with their community-based program in Wodonga. We did have to cease our program during 2020 due to COVID, and we're now re-engaging with our community participants to kind of look at what would a program look like now in this post-COVID world, and we're starting to think about how we could package our program to target some specific vulnerable population groups within the older sector. So what it will look like in the future, we're not really sure, but certainly we are really looking at how we can expand this out of the university setting through partnerships with community and community services.